Welcome back, everybody. I hope your community table conversations were productive. And it is now my honor and delight to welcome two key leaders from the University of British Columbia who are going to share some of their perspectives with us. And so we have Santa Ono, the President and Vice Chancellor of UBC, as well as Dermot Kelleher, who's the Dean at the Faculty of Medicine at UBC. And we are absolutely delighted that you gentlemen have made the time to be with us. And I will turn it over to Santa Ono to start our conversation and share his thoughts with us. So over to you, Santa.
Well, thank you very much and good morning, everyone. I'm speaking to you from the Point Grey campus of UBC. As you know, we have two major campuses, one here in Vancouver and one in the Okanagan. And as you know, we have a distributed medical program, and Dermot Kelleher will be speaking to you more about the Faculty of Medicine and UBC Health right after me, I understand. And I should just say that I was thrilled to be asked to be part of this conversation. I've been participating in an earlier community conversation, and it's been very, very helpful to me because it's clear that as a university, beyond the health professions, there's much that we can do to interact with rural and indigenous communities and to ensure that we support the youth that are interested in those professions. You will hear from Dermot Kelleher, as I said, the head of UBC Health, as well as the Dean of the Faculty of Medicine, about rural and indigenous health and it being a priority for the UBC Health, as well as for the Faculty of Medicine. Just to give you some general context, our family medicine residency program is delivered at 19 sites across the province. And I know that many of you that are here today are involved in that. And our rural continuing professional development program is committed to supporting learning needs of physicians and other healthcare workers who practice in rural and remote areas of the province. The Indigenous MD admissions program, family medicine residency program, Indigenous and certificate programs in Indigenous public health are just a few of the ways the Faculty of Medicine is helping to increase the number and retention of Indigenous health professionals in British Columbia and across Canada in response to the report of the Truth and Reconciliation Commission of Canada's calls to action. And it is something which is part of our emerging Indigenous strategic plan and the one that is in force currently. Our Faculty of Medicine is now training more Indigenous doctors than ever before, with more than 100 Indigenous medical student graduates since 2004, and a growing number completing residency training in communities across the province. I could give you similar examples from our other health faculties, pharmacy, dentistry, and nursing. And UBC Health overall is facilitating collaboration in cross-cutting health research, including Indigenous health, mental health, and diabetes. Through their work in communities across British Columbia and across Canada, our faculty, staff, and learners are helping to build a healthcare system that is more inclusive, representative, and equitable. Now, as the sole education provider in British Columbia for many health disciplines, I realize that we have a particular responsibility as an institution. UBC is uniquely placed to play a leading role in the provincial and national transition to a system that is more patient-centered, community-based, team-oriented, and evidence-informed. But one could argue that our teaching and learning needs to include a health and wellness lens, because health and wellness are dependent on many other factors, such as geography, environment, climate, social justice, and economic equity. Clearly, we know that we have work to do to integrating health and wellness throughout the university curriculum, not only in the health profession, but we are committed to doing this and to help achieve health and wellness across the entire province, especially with regard to rural and Indigenous communities. thank you for having me here today, and I look forward to the conversation and to learning about how we can serve the province even better. Thank you very much.
Thank you so much, Santa. And Dermot, if I can ask you to jump in and share your perspectives, please.
Thank you very much. And first of all, I'd also like to acknowledge that UBC's Vancouver Point Grey campus is situated on the traditional, ancestral and unceded territory of the Musqueam people, and also that you're joining us today from many places, near and far, and acknowledge the traditional owners and caretakers of those lands. I want to congratulate everybody involved in convening today's meeting. It's a meeting that clearly illustrates that here in BC, the community of practice really means the community. And as a consequence of this concept and all of the work that has occurred in the communities at UBC, all that we do in health is based on the principle of social accountability and on the principle that we have a contract with society that places the patient and the public at the center of all that we do. And we're very proud in the Faculty of Medicine, for example, to partner in the Rural Doctors UBC Chair in Public Health, the inaugural chair held by Dr. Dave Snadden. Our vision of transforming health for everyone really speaks to the heart of that contract with society, which is underscored by core values of equity, diversity, compassion, and integrity. We have 4 key principles embedded in the Faculty of Medicine strategic plan. They all begin with E, equity, excellence, engagement, and effectiveness. And we'd like to add a 5th, empowerment. If we pair equity and excellence together, this means that we're combining our ambitions in equity of access to education and equity of access to health care with the belief that what we contribute has to be excellent. And this has important consequences for our ambitions with regard to how we look at rural and remote health care. And we can only be effective by engaging with partners, such as the many groups that have gathered here today. We all have a role and responsibility to work together to provide excellence in rural and remote health care. And for us, this means broadening the scope of the way that we think about health care to thinking about health and wellness, as the President has suggested. It means broadening the scope of our distributed model to include our other health disciplines, as we are currently doing. It means looking at how we can expand our educational offerings and their reach. And it does mean thinking very carefully about how we do effective research within the rural and remote setting. This does mean empowering people to ask the right questions and to find the right solutions. And as we think about what are the right questions, it has to be said that in just over 100 days, the COVID pandemic has taught us an awful lot. Team-based training, online learning hubs, flexible learning pathways are all key to our effective responses. How we work together in a way that provides both excellence and inclusivity. The pandemic has also taught us a lot of lessons about the importance of collaboration, about joined up health disciplines, and about joined up public and acute health systems. And it's allowed us to fast track the use of virtual technology to help not only to bridge gaps, but also to innovate. And it's also taught us that we must learn to find better ways to use data effectively. And one great example of this is how the Ministry of Health and CDC charted a way through the pandemic through the effective use of data modeling. And of course, as we emerge from this pandemic, the old problems of the health system begin to re-emerge. The issues of the opioid crisis now comes back into view, and we must refocus our efforts on these issues. Now, I think it's also important that we acknowledge the weakness of our history, the darkness of our past that persists to this day, and remain steadfast in our commitment to actively promote social justice, to challenge racism and discrimination, and to address disparities and inequities. We recognize the many ways that the health system has failed Indigenous people in our province and across Canada, which is why UBC is so committed to responding particularly to the TRC and to the UN Declaration on the Rights of Indigenous Peoples. And it starts with the way that we train our students, our learners, Cultural safety and humility training are key ingredients. We'd also like to enhance access to education by improving pathways for those in rural and remote and indigenous communities. And we're working on a number of strategies right now. But one key example that was announced in 2019 is the expansion of physical therapy in the north, which begins later this summer. And on the research front, we're also very pleased to join with the First Nations Health Authority back in January to announce Dr. Nadine Caron as the founding FNHA Chair in Cancer and Wellness. To close, and integral to today's event, the call to action for everyone in this room, which is to take an appreciative inquiry approach to today's conversations, to build on what's already working, dreaming to make it better, and developing ways to realize this dream. And so we want to hear from you around things like, how do we work together to improve and enhance rural, remote and Indigenous health and wellness in BC? What's the role of an academic institution in addressing the inequities in healthcare? And how can we ensure that our education and research is equitable, diverse and inclusive? What are the opportunities and where can we go from here? We do want to hear from you. UBC is here with you. Thank you very much.
Thank you so much, Dermot and Santo. And I do hope you're both able to stay with us for the remainder of the day and continue the dialogue and continue to bring your perspectives as you shape the policies for healthcare, especially at the academic level. In addition, we've got some other leaders who also have a big part in shaping policies at the provincial level. We have the Deputy Minister, Stephen Brown of Health with us. We've got Cathy Ulrich, who's the CEO of the Northern Health Authority. And everyone has met Richard Jock, who is the interim CEO of the First Nations Health Authority. Welcome, panelists. And we have a special role for you today. It's an opportunity for you to engage with our audience and ask them questions that you're curious about. So we'd like you to think about what's the one key question that you are really, really interested in exploring. And what we would like each of you to do is get ready to ask that question. We're going to use the chat function on Zoom, and each of you will have the opportunity to pose your question, and then we'll pause and have the audience respond with their thoughts and perspectives using that chat function. And as we see what is populated in that chat function, we'll have an opportunity to dialogue with you. So this is an opportunity for us to get creative and to see what emerges from the upcoming virtual dialogue. So with that in mind, if I can potentially ask Cathy to start. I know, Cathy, you're online, and I believe Richard's online, and Stephen is on the phone. Maybe you can get us going.
Okay. Peter, I have a number of questions, and I think the first one that I would like to pose is related to cultural safety and humility, one of the themes of the summit. And my question would be, what would be your highest priority recommendation to Health Authority senior management regarding an action related to cultural safety and humility that would make the most difference from your perspective? I have a second question on that same topic, but I'll start with that one, Peter.
Great start, Cathy. Thank you. So, folks, this is your opportunity to weigh in. And again, bring your thoughts, your best advice on that provocative question from Cathy. So we'll have an opportunity to pause and Cathy, if you can start to see and read what comes up, and we'll sort of dance together around where we go with what emerges. Cathy, I'm seeing a couple of folks ask for you to maybe repeat the question. So if you could do that, that'd be great.
Yes, so the question was, what would be your highest priority recommendation to health authority senior management regarding an action related to cultural safety and humility that would make the most difference from your perspective?
Thank you. So an action that would make the most difference. So Cathy, as you're reading a couple of the thoughts that are popping up in the chat function, what's coming up for you?
I'm having a hard time keeping up with all the comments in there, and I'll look forward to seeing more. But I've seen cultural safety education. I've seen positioning people who can support cultural learning in our facilities, making sure that we've got an Indigenous voice at senior tables are some of the things that I've seen here. I think those are all really important. Really understood. The one I just saw there, elder in residence, having the youth voice. I think those are really, I think one of the themes I'm seeing is very much about ensuring that the First Nations voice is at key places within the health authority, the service delivery level, up to the senior level of the organization.
Terrific, Cathy. I think that definitely is an Uber theme that's emerged for sure. Richard, do you want to weigh in based on Cathy's summary of what she's seen as sort of that Uber theme of that First Nations voice through all aspects? Any thoughts from you on that piece?
Yeah, I see some really interesting comments, and I think they cover a wide range, right from zero tolerance to making sure that there's engagement in other than an online approach. I think there's obviously a fantastic question, Cathy, because it's really generating all kinds of good information and comments. I would say that in general, it's a concept that's sort of easy to embrace, but I think really hard to fully implement. And I think moving to that action and that implementation is really critical. So I just want to say really some fantastic input.
Thanks, Richard. Yeah, good call out there. Folks, I'm going to ask you maybe to take 10 more seconds and wind down on this particular question. And then we're going to turn over to Stephen. Stephen, I know it's a little difficult because you're on the phone, but I wondered if you can pose a question that you're curious about for our audience. So just give folks maybe 5 more seconds to wind down. 5, 4, 3, 2, 1. Perfect. Thank you. So Stephen, I'll invite you to jump in and share your curious question with the audience. Stephen, I'm not sure if you're there or if you're on mute. Okay, well, maybe Stephen will come back to you then. Richard, let me throw you in the hot seat then. What's the one question you're most curious about at this point?
Yes, thank you. And really, I have a question in a few parts. What would team-based care look like designed from the community level? And how would the community be involved with design of this team-based care? And then specifically, how would you assure that client voices continue to be heard as these team-based care approaches are implemented?
So Richard, just again, there are 2 parts to your question. Maybe just share the first one again and then highlight again the second follow-up.
So the point would be, if you had to optimally make a recommendation about how would communities be involved with design of team-based care? What would that look like? And then how would you assure that voices continue to be heard throughout the planning and implementation of that?
Okay. Great. So there's two pieces. The first one is around design. The second one is around the implementation. So again, please take a couple of minutes to put your thoughts in, and then Richard and Cathy, I'm going to ask you to read the chat function and give us your thoughts of what's emerging. Okay, lots again coming through the chat function, Richard. Anything surprises you from what you're seeing?
I'm not sure I would say surprise would be the word. I think there's some themes there that are really important. I think the idea of multidisciplinary team I saw and multi-professional groups referred to quite extensively. I think there's also a number of comments relating to making sure you have really key groups involved with the work, including elders. And I would say the other piece is the need for electronic medical records. I see that one. I think that one's really one of the ones that looks simple and I think is vital to the success, but I would say is one of the more challenging elements. But I think that one's really important. And I think the other aspect that I saw very quickly was the idea of keeping the patient at the center.
Yeah.
A number of comments on that, and I think those are among the ones that I could see from the quick scroll. So I'm not sure if Cathy had similar impressions or slightly different ones, but.
Cathy, what are you seeing?
Very similarly, I think what I saw is that we have to pay attention to three kinds of things. How do you build the relationship of the team members between themselves so they work well as a team across disciplines, inclusive of physicians and other health service providers? How do we attend to the person that we serve and their family at the center? And then people are in the context of communities, so attending then to the nature of the community. So I think if I were to summarize what I saw, I think those three kind of levels of attention and focus are needed in team-based care. The last piece I saw is one size doesn't fit all, and flexibility and adaptability to those contexts that emerge in terms of who the team is, who are the people we're serving, and in what context.
Terrific. Thank you, Richard and Cathy. You both obviously are very good at synthesizing quick information. Stephen, I'm hoping that you're on the call. Is there anything that you want to weigh in on when you hear both Cathy and Richard share their perspectives? I think we're trying to get Stephen on the call, but it's obviously a bit of a technical glitch here. We'll see if we can get him through our technical help. So maybe Tom, I'm wondering in the background if you can support Stephen to get on the call. Thank you. Cathy, why don't you go next? Pose your next question, please.
Okay, I'm going to go to virtually enhanced care because that's something that's a focus of this, this summit. And my question is balancing the need to ensure interoperability between systems with the need for flexibility and adaptability to the emergent nature of technological solution is an ongoing challenge for the system. So do you have any advice regarding how to navigate that tension?
Again, Cathy, just repeat that one more time for folks, please.
Okay. So we need to balance, the challenge is balancing the need to ensure interoperability between variety of systems with the need for flexibility and adaptability to the emergent nature of technological solutions. So do you have any advice regarding how to navigate these tensions?
Okay. So the tensions associated with technology. Cathy, a variety of thoughts are popping in there. What is emerging for you?
So I think everything from the need to be more coordinated in this space at provincial levels to keeping it really simple and practical for the people we serve and for the people who are in service delivery roles in our organizations. Those were some of the themes that I saw in this. I think an acknowledgement also that there is tension in this space and that it's something that we have to navigate. The other theme I saw in here is that we can't lose sight of the importance of longitudinal care and the in-person kinds of needs that people have, and that virtual care is, and I think it's the way it's labeled for this summit, virtually enabled care, which really talks about something bigger than just the virtual platform.
Got it.
The things I saw there.
Yeah. Richard, anything popping out for you when you think about this tension of connecting in person and having these technologically supported platforms for virtual care?
Yeah, thank you. I think there are a number of points that kind of caught my eye. One was the idea that there needs to be navigators or support persons available to help people with the complexities of the platform. And so I think that that's interesting. It sort of implies a team-based approach to also to virtual care. The other, I also saw a large number of comments on the fact that there's still not clear access to technology or to the web. So I think that that really remains a significant barrier, and I think as we go forward, we need to figure out ways to overcome that, and I would say champion connectivity in general as well. And then I saw quite a few comments relating to having common platforms, whether it be technology or EMRs. So I thought there were a number of elements there that I thought were quite important, and kind of a lot of comments just generally about this being a systems approach, and that this is can't be sort of the sole aspect of providing service, but a part of an overall system of care. So
Yeah.
very interesting comments.
Thanks, Richard. Loved your insight around access and connectivity. I think there's a big piece there, and appreciate this is a complex issue. So great question, Cathy. I think we're still struggling to get Stephen on the line here. So I'm going to ask you, Richard, to take one more question to the group, and we'll do this process just with the two of you. And at some point, try to loop Stephen back in, maybe later today or tomorrow.
Yeah, and I guess to me, I guess I would go to the COVID-19 gaps and advances. And I would say, as we go forward, what could be our optimal approach on testing if we were able to design the perfect system and look at what this means in terms of the rural context? How would we enable that? And how would this support our potential for wave 2 coming later in the year? So giving ourselves a 3-month deadline here.
Oh, okay. All right. Very clear question. And so this is an opportunity for you to put your sort of futurist hats on. Go away into the chat function again, please. And let's see what pops up. I think you've got people really thinking on this one, Richard. Haven't seen a lot of comments come up. Richard, it might be worth just summarizing again the question that you're posing.
Yes, if we were to have an optimal testing methodology or methodologies, what would it be? And what we're, just as part of the context, we're seeing rural and remote communities, but then now we're also seeing tourism and other aspects. How do you handle testing in this complex environment?
Okay, so it's really about a testing question, folks. So your thoughts, please. Give you another minute or so to weigh in. Some creative thoughts appearing there, Richard. Any themes that you see emerging?
Yeah, and I think there's sort of a competing set of interests, sort of stating it that needs to be driven by the PHO and science, and then greater access through just self-guides and other things. So I think that's an interesting set of interests. I'm surprised I didn't see point of care testing. Maybe I didn't catch it, and maybe it's not necessarily technologically available at the moment, but I think that might also be part of an access question. And I only see a couple related to antibodies. I was a little surprised on that. So I think it's an area where we obviously need more debate, or more thinking, and more push about how it could be rolled out. But I'd be interested in Cathy's comments.
Cathy, please jump in. What are you noticing?
So very similar to what Richard said. I think I also saw that it's part of a continuum of service in terms of outbreak management, contact tracing, etc. As well, it's part of a continuum of lab work in terms of making sure that there's good turnaround time, depending on whether it's point of care or something that has to be sent out to a lab. And I saw quite a bit about access and need for access close to home, and some creative ideas about how that could occur.
Terrific. Okay, as we start to wind down this piece, folks, I'm just going to ask Richard and Cathy maybe to give us, a final perspective or final comment on, how was this experience for you, and did anything stand out for you in terms of the kind of feedback you received based on your questions? So, what stood out for you, and anything that you want to highlight as you close the session down for us?
First of all, I don't read fast enough.
Okay, fair enough.
But, really good comments, and I'm hoping that they can be kept and perhaps being done, because I think there's, any of these kinds of processes bring perspectives from different walks of life, as well as life experience. And I think there's just huge value in these kind of probing questions, and then hearing what people think about those areas. And it could be an opportunity for some further dialogue as we understand some of the themes that have emerged from these thoughtful answers to the questions that we posed. So really appreciated being part of this. It's been a unique experience. Thank you.
Thank you, Cathy. And we will curate this work, so there will be a document coming back for sure. Richard, kind of same question for you. How was this experience, and your final thoughts in terms of this piece?
Well, what I would say first of all is just reading really quickly the folks that are providing the comments. There's a wide range of skills, experiences, backgrounds. So I think that's been really important, and I think the other part of it is I can see a real focus on community, an interest in community, and I really am interested in seeing how we build on that. And I know some suggestions were that we need to go to every community, and I think it's a good idea. I'm just wondering how we could achieve that practically, or achieve the results that are desired from that. But I did enjoy it, and thank you for the opportunity to be here.
Thank you, Richard and Cathy. And my provocative question to you both is, once we curate this information, how will you and your leadership teams look at this feedback, and how potentially will this then inform the kinds of decisions you make at the policy levels that you operate at? So we'll ask you to reflect on that, and potentially have you, give us your thoughts around how you would see using this kind of feedback at a future point. But on that note, thank you both for playing with us, engaging with us, and really creating a unique experience for many of us. Terrific. What I'd like to do is maybe just ask Ray Markham, is there anything that you would like to add based on your observation of what you're seeing from the various comments, and have you make the final comments to close this piece down? Ray, is there anything that you would like to add?
Well, thanks, Peter. I would say the breadth and diversity of the comments has actually been really cool. The scale and speed has obviously been a bit of a challenge, and I'm sure there are pieces that I missed. I know Richard had mentioned the point of care testing not showing up, but I think it did show up on a few cases. So I think this idea of learning for me on this process-wise is, I think there's huge value in hearing what some of our leaders are interested in. And getting a breadth of feedback. I think there's obviously a kind of a surface bit of a dialogue around that, but for sure we'll curate and, as you say, Peter, get it back in summary form to, I think, the participants, but also kind of in as much detail as Cathy and Richard and anybody else wants to kind of look at, because I think it's a great opportunity to do that. Thanks
Terrific.
everyone for their engagement. Our biggest worry was that there'd be silence on the chat box, and that was definitely not the case. It was quite the opposite, so that's great.
Yeah, nice observation, Ray. Thank you. Thank you again to our two panelists, Cathy and to Richard. And we will obviously loop Stephen in at a further point, and we appreciate that something has come up for him. So just before we break, folks, I want to remind you we are going to go into the peer group tables. And so the peer group tables are tables that have been designed really to take the work that you're doing at the community level and start to, at this initial stage, think about, so what do we do about it? The peer groups really are powerful mechanisms for people with shared interests and common perspectives to find ways not only to collaborate, but to take these possibilities and move them from that describing and dreaming stage into some sort of mutual accountability and action. So that's what we're starting to do, is really create those groups to do that. And just to remind you, we have a number of peer groups, and some of you have actually indicated which peer groups you're from, but there's academia, there are citizens, I think that Thomas is showing that slide, linked sectors, policymakers, healthcare administrators, and healthcare providers, obviously, First Nations, and there's a sort of an open category. So this is where it's going to get a little bit interesting and potentially, again, messy. That's the word of the day, is when you go into the peer groups, you might find yourself in a group of 100 people. And what we'll need is your patience to sort out a group that can actually have a conversation. And so, it might take a little bit of time to get that going. The other piece we'd like you to encourage is don't feel like you have to feel like you getting to some result in this particular conversation. I think it's really more important for you to form the groups and start to develop the relationships, because you will have another opportunity tomorrow to actually move into solving some of the questions that have been posed. But for now, take the time to organize your group, start to get the experience of deepening your connections in a way that will really help you start to address this set of complex questions in a more sort of, I would call, deeper way, especially tomorrow. So this is your opportunity to just practice some patience with us as we now go into the peer group process. And before we do that, I'd like to ask your indulgence for one more piece that we'll do as a group, and that is a sort of a check-in question. And Tom, will you put that check-in question on the screen, please? Thank you. If you could just take 30 seconds to complete this check-in question before we ask you then to sign off and move into your peer groups. And as you fill in that little poll, remember this is the last time we'll be together in a full plenary session, and we will see everybody tomorrow at 8 o'clock for our second day kickoff. Okay, thanks very much, everybody. Appreciate the check-in question and your response. And on that note, enjoy the time in your peer groups. And if there is any technical difficulties, we are running into some phone system issues, please just email to info@rccbc.ca if you're struggling. So on that note, we're going to close this webinar piece and allow you to take a few minutes to get into your peer groups, with the caveat that it might be a little bit messy as you start the process. And please just go with it, and we know that it will all work out.